Thank you, Marilyn, for the introduction. And I'm glad to present the impact of systematic TB detection. There's a lot of evidence showing that TB is a common cause of pneumonia in children. A lot of literature has been published. And it's very important to note that when these children with TB present with pneumonia, they often have acute onset symptoms. However, we know that we only suspect TB in children if they've had the symptoms for a long time, or if they fail to respond to antibiotics, or if there's a positive contact with TB. And for that reason, the diagnosis is always delayed, or actually missed completely. So in this context, the TB study group therefore set out to assess the impact on 12-week mortality of adding systematic TB detection using expert MTB Reef Ultra on nasopharyngeal aspirates and stools, and they added this to the WHO standard of care for children less than 5 years with severe pneumonia. There were several secondary objectives, which included TB detection at 12 weeks, TB treatment initiation and time to TB treatment initiation, inpatient mortality, duration of initial hospitalization when the child came to hospital, hospital readmission rate, weight gain at 12 weeks, and cost effectiveness. So we carried out a step-weight cluster randomized trial in 15 tertiary level hospitals in 6 high incidence countries that were spread across from west to central through east to South Africa. And the hospitals, which were the clusters in this case, were stratified on estimated TB incidence in a country. And we defined a high incidence country as a country that was reporting incidences of 100 to 300 cases per 100,000 population, and Uganda is in one of these. And very high incidence as countries reporting incidences more than 300 cases per 100,000. The target population were children aged 2 months to 15 months who had WHO classified severe pneumonia, which we shall see very soon. The intervention was systematic early detection of TB with expert ultra, and this was performed immediately as soon as the child was admitted in hospital to 1 nasopharyngeal aspirate and 1 stool sample. And if it was positive, the child was treated immediately. And this was in addition to the WHO standard of care, which we shall see very soon. So the WHO standard of care was the control arm. The primary endpoint was all-cause mortality at 12 weeks. Yeah. So just a little bit about the step weight and how we applied it. So it's a type of cluster randomized trial. And in this case, all hospitals started in the control arm, and all of them ended in the intervention arm. A cluster was added to the intervention arm after every 5 weeks, and it should have taken a total of 8 weeks to have included all the hospitals. We had a COVID break. We had a break in enrollment in all hospitals, and we stopped at a go during the COVID outbreak for around 7 months. So severe pneumonia, according to the WHO, is defined in a child who must have either a cough or difficulty in breathing and any of those 11 listed symptoms, including peripheral oxygen saturation of less than 90, central cyanosis, severe respiratory distress, and any child with signs of pneumonia and a danger sign. So the standard of care of WHO for managing pneumonia consists of immediate admission of the child, administration of either IM or intravenous antibiotics, oxygen therapy if the stats are less than 90%, and supportive care according to the child's need. The child must be monitored every 3 hours and must be followed up 2 weeks after discharge. If the child is found to have HIV, they must be treated with ART, and if the child is malnourished, they have to refuse to receive therapeutic feeds. So the intervention arm consisted of molecular testing with expert MTB, brief ultra, on microbiological samples, which were nasopharyngeal aspirate and stool, and this had to be done in the ward for the nasopharyngeal aspirate or the hospital lab, which is nearby, and in the lab for the stool. However, the results had to be returned within 3 hours so that the child receives immediate treatment. So for statistical analysis or impact of intervention, we conducted an intention to treat analysis using a generalized linear mixed effect model for binomial endpoint, taking into account for clustering. We also carried out sensitivity analysis for the primary endpoint with a protocol analysis in children for whom the standard of care was applied with ultra performed on at least one of the samples. We also carried out secondary endpoint analysis comparing between the two arms using the same covariates as what was done for the endpoint. A post hoc analysis was carried out again for the primary and secondary endpoints, comparing each trial arm in children who had severe acute malnutrition. Is it possible to remove that line under that says epicenter TB blah blah blah? Because there is work that cannot be seen. Huh? Okay. So out of the 5,283 children screened, 3,661 were had pneumonia. Out of these children who had pneumonia, 2,570 were enrolled. 1,401 were enrolled during the control period, while 1,161 were enrolled during the intervention period. In the control period, 93 children received antibiotics, and out of those, around 548 required oxygen because their stats were below 90. And of these, 96% received oxygen. In the intervention arm, 97% of the children received antibiotics and 98 received oxygen therapy because their stats were low. 99% of the children had ultra on at least one sample of either stool or NPA, while 77% had both samples tested, both stool and NPA. All the children enrolled were included in the analysis. So considering the baseline characteristics, we see that children were relatively young, as expected anyway, with a median age of 11 months. We note that children in the control arm had lower oxygen saturations compared to the children in the intervention. However, children in intervention were more likely to be malnourished, had more malnutrition compared to the intervention arm. Also note that children in the control arm, their respiratory rates were higher compared to the children in the intervention arm. On feasibility of nasopharyngeal aspirate and stool sample collection in the intervention arm, of course, we find that this was very feasible because out of the 1,169 children in the intervention arm, from 98 of them, the NPA was attempted and was successful in 97.4%. 96 of these were tested on ultra. 80.7% of the children provided stool out of which 79.9 was tested with ultra. Of the NPA that was tested, 1.8% tested positive, while 0.9% of the results were invalid. And the stool, 1.4% tested positive, and again, 0.9% of the results were invalid. The primary endpoint, we note that the intervention had no impact on reducing mortality at 12 weeks, after 12 weeks. This is just saying that even after adjusting for severe acute malnutrition, there was still no impact on mortality. So the sensitivity analyses that were done on the different parameters confirmed the result that there was still no impact on mortality. So if we go back now to the samples that were tested, we note that 24 of the children, which is 2% of the whole sample, who had ultra, on either stool or sample, 24% came out positive of other children that were tested. Some children, TB was diagnosed using either the clinical acumen or radiologically, and these were around 65, bringing the whole total of children diagnosed with TB to 89, which was 7.9%. It's very important to note here that the number of children in whom microbiological confirmation was good, which was 27%, combining both ultra and NPA, rather NPA and stool on ultra. Concerning the secondary endpoint, we observed more TB diagnosis at 12 weeks and more microbiological confirmed TB in the intervention arm. A reduction of time to TB treatment in the intervention, together with less readmission. And these differences were, however, not significant when adjusting for severe acute malnutrition was carried out. For severe adverse event of nasopharyngeal aspirate, we considered the tolerance of the child, and we note that very few cases of intolerance were reported. For example, nausea and vomiting, 3.1, and so on. The only thing that was relatively high was maybe a bloody sample, 27.3%, and dyspnea in 11.4% of the children. It's important for me to let you know, though, that dyspnea was reported mainly from one facility, and probably it could have been a technique of over-reporting. Okay. So in order to better understand our results and better understand why some results were not significant, we carried out adjusting for some. And we note that if you compare the children with the severe acute malnutrition with the children without severe acute malnutrition in both arms, we note that the deaths were actually more in children with severe acute malnutrition. We also note that children who had severe acute malnutrition, among them, more TB was diagnosed microbiologically compared to children without some. So in conclusion, we would like to state that screening with ultra at the time of admission did not lead to reduced mortality overall in children with severe pneumonia. Death occurred very early in the follow-up. Early deaths may not have been averted, probably, even if the intervention would have been effective. Microbiological sample collection and ultra testing were highly feasible, and combining both the NPA and stool, even if the yield was rather low. high TB treatment initiation and microbiological confirmation rate support the more systematic use of ultra in children with severe acute malnutrition. And we recommend for a paradigm change for causes of pneumonia to consider TB seriously as a cause of acute pneumonia in children. And like the rest of TB speech, we recommend further research in biomarkers to identify children with high risk of TB. So thank you very much for listening to me. And I acknowledge the sponsors, the funders, the participants, and all of you. Thank you.